Good evening, Dr. Phil here. Today we'll be discussing on the prone position. Indications for prone position during anesthesia for neurosurgeries, neck surgeries, spinal surgery, laparoscopic assisted esophagectomy, colorectal surgeries, vascular surgeries and tendon repairs. In critical care for ARDS. Contraindications in the unconscious patient. Absolute contraindications includes shock, spinal instability, multiple fractures or trauma, acute bleeding, raised intracranial pressure, reduced cerebral perfusion pressure, tracheal surgery or sternotomy within 2 weeks, anterior burns, and pregnancy. Relative contraindications includes difficult airway or difficult intubation, thoracic and abdominal surgeries, recent DVT treated for less than 2 days, anterior chest tubes with air leaks, cardiac abnormalities such as freshly placed pacemaker, life-threatening arrhythmias, ventricular assist devices or balloon pumps. These devices may be dislodged or immediate access for CPR may be needed urgently. Severe burns, prior use of rescue therapies, lung transplant recipient, and clinical conditions limiting life expectancy. Obesity is not generally considered a contraindication. In the awake patient, additional absolute contraindications include impending respiratory collapse, where intubation is more appropriate, recent abdominal surgery, the uncooperative patient, and others as above mentioned. Relative contraindications include anticipated difficult airway, neurological issues such as seizures, patient unable to adjust position independently, pressure sores, and others as above mentioned. Variations of the prone position. There is no standard prone position. There are many variations such as the knee-chest tuck position and jackknife position. Different variations are associated with different physiological effects, advantages and disadvantages. Kindly refer to the article by H. Edcombe et al. In 2008, Anesthesia in the Prone Position. The following discussion is a generalization which applies primarily to a prone position in which the patient is straight, flat, pelvis and shoulders are supported to leave the abdomen free, and the head is centralized and neutral. Physiological effects of the prone position. Respiratory system. There is increased FRC when compared to the supine position as long as abdominal movement is unimpeded. When the patient transitions from conscious upright position to supine anesthetized position, FRC decreases by 45%. However, when the patient transitions from upright position to prone anesthetized position, FRC decreases by 12%. PaO2 increases when the patient transitions from supine to prone, with all other factors unchanged due to better matching of ventilation and perfusion. As long as abdominal movement is unimpeded, PaO2 increases. Prone ventilation increases matching of ventilation and perfusion. The gravitational theory suggests that pulmonary blood flow favors the dependent areas of the lung. Better matching of ventilation and perfusion occurs due to gravity displacing the heart and smaller volumes of the lung being compressed, and improved diaphragmatic excursion unhindered by the intra-abdominal contents. The model based on the branching architecture of the airways and pulmonary vessels challenges the gravitational theory. Single photon emission computed tomography measurements in healthy ventilated patients have shown no change in the distribution of ventilation from supine to prone, a more evenly distributed pulmonary blood flow, and improved matching of ventilation and perfusion. There is substantial heterogeneity of ventilation and perfusion at isogravitational levels, which is related to the fractal characteristics of pulmonary architecture, but at any particular level there is appropriate VQ matching. The prime dependents of ventilation and perfusion are the shape and structure of the bronchioles and the blood vessels. Dorsal lung areas receive preferential perfusion independently of position, and this may be related to an intrinsically lower pulmonary vascular resistance in those regions. In the injured lung, the proximal architecture of the bronchioles and vessels may be distorted by edema and inflammation. This mismatch can be amplified by the distal branching with substantial VQ mismatch in the alveoli. Kindly refer to the prone ventilation for ARDS section for further details. Abdominal pressure exerts pressure to the diaphragm. This increases intrathoracic pressure. reduces thoracic compliance, causes basal atelectasis, and increases lung inflation pressures, particularly in obese patients. Effects on the cardiovascular system. There is reduced cardiac index. Reduced venous return results in reduced preload, reduced stroke volume, and reduced cardiac output. Reduction in preload may be due to blood sequestration in dependent body parts during prone position, caval compression, increased intrathoracic pressure with poor positioning and chest wall compression, and positive pressure ventilation and PEEP. Prone positioning with or without abdominal compression results in venous pooling with or without IVC obstruction, reduced venous return, stroke volume, and cardiac output. Positive pressure ventilation results in abolishment of negative intrathoracic pressure, reduced venous return, reduced stroke volume, and reduced cardiac output. Anesthetized patients may tolerate poorly rapid changes in position. Compensatory sympathetic response occurs with increased heart rate, systemic vascular resistance, and pulmonary vascular resistance. Pulse pressure and stroke volume variability. Variability in pulse pressure and stroke volume are greater in the prone position compared with the supine position. Both can be used to predict whether the anesthetized ventilated prone patient will respond to a fluid challenge. Patients with a pulse pressure variation of more than 14% are likely to respond to a fluid challenge. The type of prone position adopted can affect the changes observed in cardiovascular physiology. Prone on the Jackson table causes the least effect on all cardiovascular parameters. Prone on the Wilson table and Andrews support the knee-chest position results in more reduction in cardiac index. The jackknife prone position results in reduced cardiac index, reduced heart rate, increased mean arterial pressure, and these values return to the supine values when the patients are placed in the Trendelenburg position. Effects of prone position on cerebral blood flow. Vessel distortion may occur from rotated head position, flexion or extension of the neck, and via external pressure, partial occlusion of the internal carotid and vertebral arteries, spinal vessels, and compression of venous drainage results in reduced cerebral blood flow and increased ICP. The head and neck should be kept in a neutral position during turning and while in a prone position. Effects of prone position on renal function. A small study in non-anesthetized healthy volunteers has shown slight increase in urine output in the prone position, but no difference in renal sodium excretion. Complications during the prone position. Airway complications includes loss of airway and airway obstruction. Secure the airway before turning the patient. Have a stretcher immediately available if there is a need to turn back to supine emergently. Airway obstruction may be due to bloody secretions, insipited sputum plugs, kinking of airway, etc. Ophthalmic complications includes supraorbital neuropraxia, corneal abrasions, chemosis, subconjunctival hemorrhage, dislocated intraocular lens, fixed mydriasis, retinal detachment, central retinal vein occlusion, ophthalmoplegia, cavernous sinus thrombosis, painful orbital compartment syndrome, non-traumatic subperiosteal orbital hemorrhage, emarosis, increased intraocular pressure, and visual loss. The general post-operative risk of prolonged visual loss is 0.008% and is 0.02 to 0.2% following spinal surgery. The two mechanisms includes central retinal artery occlusion via direct pressure on the globe and ischemic optic neuropathy via inadequate oxygen delivery to the optic nerve. This can occur without any pressure on the globe or orbit and may be due to reduced venous drainage and increased interstitial fluid around the optic nerve, resulting in compartment syndrome. The majority of post-op visual loss cases are not associated with direct pressure on the globe. Risk factors for post-op visual loss includes hypotension, blood loss more than 1 liter, increased venous pressure, anemia, length of procedure more than 6 hours, direct compression on the globe, atherosclerosis, diabetes, hypertension, and the male gender. Perfusion of the optic nerve. The ophthalmic perfusion pressure equals MAP minus IOP or venous pressure, whichever is greater. The prone position may increase intraocular pressure, increase venous pressure, and may reduce cardiac output, resulting in reduced MAP. Increased intraocular pressure or venous pressure or reduced arterial pressure increases the risk of developing optic nerve ischemia. Increased intraocular pressure has been demonstrated in both the awake and anesthetized-prone patient in the absence of extraocular pressure on the globe. Intraocular pressure tends to increase with the duration of prone position, but not all studies have demonstrated this. Suggested mechanisms why increased IOP occurs during prone position includes prone positioning results in increased venous pressure and peak inspiratory pressure results in increased IOP, reduced choroidal blood flow with reduced outflow of aqueous humor. This results in reduced perfusion pressure to the optic nerve head and ischemic optic neuropathy. Impaired arterial autoregulation under anesthesia may result in increased intraocular blood volume and increased IOP. Altered circulation of aqueous humor and administration of large volumes of IV fluids may increase IOP. Reduction in ophthalmic perfusion pressure may be due to hypotension, hypovolemia, reduced cardiac output from abdominal compression, direct orbital pressure, increased venous pressure, and reduced blood flow via central retinal artery thrombosis. Some individuals may have anatomic variation in the arterial supply or abnormal autoregulation of that supply, and this makes them susceptible to ischemic optic neuropathy. Management of post-op visual loss. Preoperatively, consider pre-op counseling for all patients or selectively to those groups deemed to be at high risk. Intraoperatively, avoid external pressure on the eye, maximize venous outflow from the eye by neutral head and neck position with no venous compression, and keeping the head above the heart by means of a slight head-up tilt. Consider maintaining intraocular perfusion and oxygenation by maintaining a minimum systemic pressure, increased transfusion trigger in high-risk patients, and manipulating intraocular pressure. Post-operatively, consider telling patients to seek medical attention if they experience persistent blurring of vision or visual loss post-op, and post-op eye checks. Visual loss, if occurs, is usually irreversible. Various treatments produce varying degrees of success, such as urokinase, PGE1, hyperbaric oxygen therapy, and stellate ganglion block for central retinal artery occlusion. CNS-related complications during prone positioning. Arterial occlusion. Flexion, extension, or rotation of the head during prone position may cause hypotension or arterial hypoperfusion, resulting in ischemic stroke of the brain or spinal cord. For example, via carotid or vertebral artery occlusion, patients with arterial stenosis may be at greater risk. Carotid artery dissection and vertebral artery dissection. The head and neck should be kept in a neutral position during turning, and while in a prone position, vessel distortion may occur from rotated head position, flexion or extension of the neck, and external pressure, partial occlusion of the internal carotid and vertebral arteries, spinal vessels, and compression of venous drainage may reduce cerebral blood flow and increase ICP. If rotation of the head is required, take care not to overextend or flex the cervical spine. Venous occlusion. Venous occlusion may cause increased venous pressure. Other causes of increased venous pressure include head-down position, positive pressure ventilation, chest rolls, pre-existing abnormal venous anatomy such as stenosis of jugular foramina in achondroplasia, and occipital meningioma obliterating the superior sagittal sinus. Increased venous pressure with arterial hypotension may result in reduced perfusion pressure to the spinal cord or brain and may result in ischemia. Air entrainment. This can occur during posterior fossa or cervical spine procedures in the prone position and may cause tension pneumocephalus, pneumorrhesis, which is air entrainment into the spinal canal, and quadriplegia, air embolism with or without cardiac arrest. Cervical spine injury. Vertebral disc prolapse, excessive neck flexion or extension, and spinal dislocation may cause spinal cord injury. Thus, the head and neck should be kept in the neutral position during turning and while in the prone position. Careful positioning of the neck is essential to prevent neurological injury. Effect of undiagnosed space-occupying lesions such as spinal arachnoid cyst, spinal metastasis, frontal lobe tumors, and neurofibroma. Space-occupying lesions within the spinal canal or cranial cavity can become symptomatic as a result of prone positioning, possibly due to altered CSF flow, epidural venous engorgement, or compression of the brain and spinal cord. For example, an undiagnosed pedunculated neurofibroma in the posterior fossa fell anteriorly when prone in a case, resulting in compression of the medulla and pons, bradycardia, and fatal neurogenic pulmonary edema. Surgical bleeding. Venous drainage from the spine is via the vertebral valveless venous plexus of Batson. External compression may increase intra-abdominal pressure, and this increases surgical bleeding during spinal surgery. Peripheral nerve injuries. Frequency of peripheral nerve injury after surgery in any position is 0.1%. Nerves may be damaged via ischemia from compression or stretch injury. Examples of nerves that may be damaged during prone positioning includes the supraorbital nerve, lingual and buccal nerves, for example when stretched between masseter muscles as a result of inadvertent jaw retraction in the prone position, the phrenic nerve and recurrent laryngeal nerve via overextension or rotation of the neck, brachial plexus injury. Traction injury may occur as the brachial plexus is effectively fixed at the cervical vertebrae. Compression injury may occur at the level of the first rib, clavicle, and the head of the humerus as they pass down into the upper limb. Other nerves that may be damaged includes the ulnar nerve, axillary nerve, musculocutaneous nerve, radial nerve, lateral cutaneous nerve of the thigh, sciatic nerve, common peroneal nerve, and dorsal nerves of the penis. Risk factors for peripheral nerve injuries includes diabetes, extremes of body habitus, pre-existing neuropathy, peripheral vascular disease, anatomical variants, male, prolonged hospital stay, advanced age, alcohol dependency, history of peripheral nerve injury after prone position, etc. Presentation. Symptoms often only occur after 24 hours, with more than 90% of cases presenting within 7 days. Symptoms may be sensory or mixed motor-sensory. 53% of patients will recover within a year. Those with sensory loss are more likely to make a full recovery compared with those with a mixed motor-sensory deficit. 25% will suffer persistent pain. Assess the patient's ability to tolerate the proposed operative position when they are awake when possible. SSEP monitoring is used in some centers for detection of impending nerve injury. The head and neck should be in neutral position. Avoid positions that cause excessive stretching or compression of nerves. Upper limb placement. Placing the arms by the side provides the greatest protection for the ulnar nerve and the brachial plexus. If the arms are to be abducted, they should have less than 90-degree bend at the elbow or shoulder. Avoid direct pressure in the axilla to protect nerves and vessels. Elbows should be well padded. The rotator cuff can be damaged during positioning of the arms. For lower limb placement, pressure areas should be well padded. Avoid positions that can cause excessive stretching or compression of nerves. Pressure sores and pressure injury. Causes includes via direct pressure on the affected tissue and indirectly via pressure to the vascular supply and drainage of the injured area. Pressure injuries may occur at tissues overlying bony prominences such as the forehead, cheeks, chin, thorax, ASIS, knees, anterior ankle joints, genitals, etc. If compression occurs for more than 2 hours, ischemia may occur, and if compression occurs for more than 6 hours, tissue necrosis can occur. Risk factors for pressure injuries includes malpositioning, inadequate padding, increased duration of surgery, skin fragility associated with advanced age or corticosteroids, obesity, etc. Direct pressure injuries includes skin necrosis, contact dermatitis, for example, to polyurethane foam or BRS monitor, pressure injuries of the eyelids, pinna, nose, cheeks, tongue, chin, and iliac crest, salivary gland swelling. With the head rotated, there may be stretching of the salivary ducts, producing stasis and acute swelling. Tracheal compression is associated with thoracic scoliosis, which has reduced anterior-posterior diameter of the chest. This increases the risk of compression of the trachea between the spine and the sternum. Trachea compression may be exacerbated by an underlying connective tissue defect of the trachea such as Marfan syndrome or tracheomalacia. Shoulder dislocation. Anterior dislocation of the shoulder may lead to compression of the axillary artery and loss of pressure trace in a radial artery cannula. Breast injury, injury to the genitalia, and compression of the femoral neurovascular bundle can occur via direct pressure. Examples of indirect pressure injuries include macroglossia and oropharyngeal swelling. Possible causes: excessive flexion of the head with presence of a tracheal tube results in kinking and obstruction of the internal jugular vein in the neck. This obstructs venous drainage from the lingual and pharyngeal veins. Multiple intubation attempts with or without attempts for orogastric tube insertion and esophageal temperature probe insertion, and anatomical abnormalities of the skull base might predispose to venous obstruction. If oropharyngeal swelling occurs, this may require delayed extubation or emergency tracheostomy to relieve upper airway obstruction if extubated prematurely. Mediastinal compression. The chest wall may not be sufficiently robust to allow the patient's weight to be supported on it without compression of the structures within under circumstances such as congenital anatomical abnormalities, after cardiothoracic surgery, scoliosis, and pectus excavatum. Mediastinal compression may lead to cardiac or great vessel compression, reduction in cardiac output, shock, and myocardial ischemia. Visceral ischemia. The liver may be compressed, resulting in progressive metabolic acidosis, raised liver enzymes, and hepatic infarction. The pancreas may be injured via indirect pressure. Pancreatitis may be associated with prone positioning, scoliosis surgery, hypotension, blood loss, drug effects, or the use of a cell saver. Avascular necrosis of the femoral head. Hypotensive anesthetic technique with increased venous pressure from the prone position may result in intraosseous hypertension and ischemia of a compromised femoral head. Peripheral vessel occlusion, such as the axillary artery, femoral artery, and external iliac artery may occur. The four-post Relton Hall spinal frame may occlude the femoral artery or external iliac artery by external pressure. Limb compartment syndrome and rhabdomyolysis may occur. This is associated with prone positioning involving flexion of the hips and knees and prolonged surgery lasting more than 3 hours. Embolic complications. Gas embolism may occur. Kindly refer to the video discussing gas embolism for further details. Non-gaseous embolism, examples include fat, cement, and bone fragment emboli. It is not clear whether these are specific to the prone position or would have resulted anyway from the nature of the surgery, regardless of position. Airway access. The armored endotracheal tube is the safe exam answer. Restricted access to the airway once the patient is inverted mandates endotracheal intubation. The armored design prevents kinking. Fasten the endotracheal tube securely. Laryngeal mask airway is used either as a primary adjunct or as a rescue measure in the event of airway difficulty. The use of laryngeal mask airway as the airway during prone position is contentious. However, it has been used effectively. LMAs are relatively easy to resite should it move, unlike a tracheal tube or reinforced LMA. It is claimed that the drainage tube allows easier detection of displacement during positive pressure ventilation, and the shape of the LMA supreme makes accidental rotation displacement less likely. LMA has been placed after prone positioning, having requested the patient to position themselves awake. This may avoid other adverse events related to the prone position, such as soft tissue and nerve injury or spinal destabilization. However, this runs the risk of inability to maintain an adequate airway once anesthesia has been induced. LMA was used with a tracheal tube and an airway exchange catheter as a backup route for ventilation and possible reintubation in the event of accidental extubation in a patient with a stenosed saber-sheath trachea. In certain patients, the airway may be more easily managed with the patient prone and may be more protected from regurgitation. In almost all patients, the tongue will fall forward in the prone position and airway will tend to remain open. In most patients, the advantage is small, as there is no difficulty in airway maintenance in the supine position. The following are examples of special cases. A case report presents a case of Pierre-Robin syndrome where the trachea was intubated nasally, blind in the prone position. Trauma cases. An adult with facial trauma who presented awake and prone because of a threatened airway successfully underwent awake fiber optic intubation prone. Another patient who presented prone to the emergency department with a drill bit protruding from his neck, the tip of which was in the spinal canal, was managed with manual inline stabilization, inhaled induction, and placement of an LMA, through which he was ventilated without the use of neuromuscular blocking drugs. The DAS guideline for difficult extubation do not address extubation after prone surgery. A leak test may be performed after prolonged procedures for cases performed in the prone Trendelenburg position before extubation to assess for airway edema. Commonly used operating tables and supports during prone positioning. Pillows. Use case for quick cases. Advantages: it is quick to set up. Disadvantages: there is limited chest support, difficult to ensure a free abdomen as they are easily compressible, and pillows can move during the procedure or positioning. Chest rolls. Advantages: it is easy to ensure a free abdomen. Disadvantages: pressure injury, and they are associated with hepatic failure when poorly positioned. Pelvic roll. Use case to elevate the anus and rectum. Disadvantage: pressure injury. Thoracic support or Montreal mattress. Use case: cervical and thoracic spinal surgery, esophageal surgery, and urological surgery. Advantages: they come in different sizes. They are easy to store and place on the table. They allow free abdominal movement, and it is easy to place the arms by the sides or flexed and abducted. Disadvantages: pressure to the groin may occur if incorrectly sized. The Allen table or Jackson table. Use case: spinal surgery, especially with instrumentation requiring radiology access. Advantages: the abdomen and chest are free. Some have a specific arm support and a mirror to permit easy view of the face and tracheal tube. It is excellent for the use of C-arm image intensifier. It permits wide range of rotation of the patient. Movable supports allow the frame to be adjusted to the individual patient. There is minimal change in cardiovascular physiology. The table can be used to turn the patient prone. Disadvantages: large piece of equipment. The patient's head is distant from the anesthetist and it is difficult to access the airway. Cumbersome control mechanism for height and rotation for the Allen table. Dual control to operate both the theatre and operating tables. The torso is on the operating table and the legs on the theatre table for the Allen table. Wilson frame or reverse saddle support. Use case: lumbar spinal surgery. Advantages: it permits the loss of lumbar lordosis. Pressure is distributed across the patient's sides, so the pelvis and chest is supported while the abdomen remains free. Disadvantages: it can only adjust the width of supports, and this may result in the supports being too long for certain patients. It is difficult to position the arms by the sides. The Cambridge frame or Relton Hall frame. Use case: scoliosis surgery. Advantages: it can be adjusted for each patient and allows good X-ray access. Disadvantages: the patient rests on 4 pressure points only, and this may cause skin necrosis during prolonged surgery. Andrews frame. The knee-chest position. Use case: for occipital, cervical, lumbar, perineal or perianal surgery. Advantages: it permits the loss of lumbar lordosis. It provides excellent surgical access to the spine and perineal structures. Disadvantages: decreases in cardiac index and stroke volume occurs due to venous pooling in the legs. Pressure injuries to the knees and lower limb nerves may occur. Andrews frame requires chest roll, and the chest can be unstable. Multiple people are required to position the patient on the Andrews frame. Head support. Mayfield clamps and pins. Use case: for craniotomies and cervical spinal surgery. Advantages: there is no direct pressure on the eyes. It provides easy access to the tracheal tube. Disadvantages: there is risk of scalp lacerations, and there is no support for the tracheal tube. Preformed foam, such as the Disposa View. Use case: for all cases, newer preformed foam masks are marketed as being suitable for up to 8 hours of use. Advantages: it provides easy view of the eyes. It is preformed and easy to check positioning. Disadvantages: one size does not always fit all. Pressure injury if used during prolonged surgery. It is difficult to access the tracheal tube. It is expensive and not reusable. It has a too low of a profile for double lumen tubes. Gel support. Use case: for all cases. Advantages: different types with different height profiles are offered. The higher profile support permits use of the double lumen tube. It is reusable. Disadvantages: the shape is distortable so the head can move. It is difficult to check for pressure on the eyes. The horseshoe head support. Use case: for quick procedures. Advantages: it is easily available. If used as a table extension, it ensures the face is free and easy access to the airway and tracheal tube is provided. Disadvantages: the support can change position when the patient is moved. Gel ring. Use case: for quick procedures. Advantages: it is easily available. Disadvantages: the patient's head must be turned, and this risks vessel, nerve, or bony injury. Pillows. Use case: for quick procedures. Advantages: it is easily available. Disadvantage: the head must be turned, and this risks vessel, nerve, or bony injury. Anesthetic management during the prone position. Preoperative management. History. Assess whether there is pre-existing visual defect, pre-existing neurologic deficit, comorbid cardiopulmonary disease, pre-existing pressure source, and others as indicated by clinical background or surgical procedure. Physical exam includes neurologic exam, range of motion of limbs and neck, and others as indicated. Lab test includes hemoglobin levels and others as indicated. Informed patient consent of risk of prone position should be obtained. Consider consults such as ophthalmology if visual defect present, and others as indicated. Optimization goals includes avoidance of visual loss, no direct pressure on eyes, limit blood loss and anemia, maintain normal mean arterial pressure, avoid increases in ophthalmic venous pressure, and keeping surgery less than 6 hours if possible. Avoid excessive thoracic pressure, which may compromise ventilation. Avoid excessive abdominal pressure, which may compromise hemodynamics and ventilation. Anticipate and prepare for significant blood loss. Good vascular access. Accurate blood loss measurement, GSH or GXM. Consider cell salvage. Avoid neurologic injury. Proper positioning, inspection, adequate padding. Arms should be less than 90 degrees abducted. Keep the neck in neutral position. To avoid carotid or vertebral artery occlusion and cervical spine injury, avoid excessive neck movement, spinal cord function monitoring during spine surgery. Anticipate significant heat loss for long procedures. Employ passive and active warming. Avoid air embolism, which is more common during neurosurgery. Options includes general anesthesia with armored endotracheal tube, or neuraxial or regional anesthesia. Intraoperative management. Pre-medication, blood products, ICU or step-down bed is determined by the clinical background and surgical procedure. Room setup. Specialized OR table or mattresses may be required. This may allow unhindered movement of the abdomen and chest and should be used to minimize complications such as the Jackson table and Montreal mattress. Adequate padding, bolsters, and prone face padding. Monitoring, standard or additional as elaborated below. For major procedures, include standard monitoring, invasive arterial blood pressure monitoring with indwelling urinary catheter for accurate assessment of volume status. Transesophageal echocardiography may be a useful adjunct in assessing cardiovascular status in a patient with complex disease. TOE may also enable early detection of circulatory arrest and prompt management and may help detect air embolism. CVP is rarely required. CVP is difficult to interpret in a prone position. Spinal cord monitoring may be required for spine surgery. It is a specialist service provided by a neurophysiologist. Somatosensory evoked potential monitoring is the most commonly employed technique. Secure venous access. Options include peripheral or central lines. Extension with a three-way type helps, as it may be difficult to access the cannula. Choice of anesthetic depends on clinical background and surgical procedure. Examples include IV induction with muscle relaxation and opioid supplementation, or low-flow volatile anesthesia or TIVA with or without remifentanil. Saxametonium. Avoid this drug in patients with paraplegia or large areas of muscle denervation from 2 days to 8 months of onset. Secure airway. Airway access is limited. Options have been discussed in a previous section. Oral endotracheal intubation with a non-kinking tube is usual, secure with adhesive tape or film. Intubation using awake fiber optic intubation or with manual inline stabilization for patients with unstable necks, such as due to trauma or rheumatoid arthritis. A throat pack may be used to decrease the flow of secretions onto the pillow. Secure other lines as needed, such as arterial line, urinary catheter, temperature probe. Induce supine on the stretcher, then turn the patient prone. Turning the patient from supine to prone requires log rolling by a trained team and is physically demanding. Ensure adequate hypnosis and pre-oxygenation with a fraction of inspired oxygen of 1 prior to moving the patient. 6 or more members of staff are needed to position a patient prone. The first member is usually the anesthetist at the head, except in cases of unstable spine injury. 1 moving the feet, 2 on the right side of the patient, another 2 on the left side of the patient, additional members for obese patients or for patients with unstable spines requiring log rolling. Avoid applying twisting forces in the axial plane, especially for the poorly supported cervical spine, which may be unstable due to fractures or degenerative disease. The head must move as one with the shoulders. The surgeon should be part of the team proning the patient. Disconnect monitoring, infusions, and the breathing system just prior to turning the patient. This reduces the risk of accidentally dislodging lines or the tracheal tube. Care not to dislodge whichever airway device and IV or arterial lines that are in place. However, do avoid disruption of lines and monitors as much as possible. Keep the duration of any disruption to a minimum. Reconnect all lines, monitoring, and breathing circuit once the patient has been prone as soon as possible. Specialized equipment such as the Jackson table can be used to turn the patient prone. Specially designed mechanical hoists can be used to transfer the patient from the trolley to the operating table. Check the position of the ETT when the patient has been turned. Check that ventilation is adequate without excessive inflation pressures prior to surgery. Increased airway pressures, for example more than 5 cmH2O, once prone position, should trigger a check for causes such as bronchospasm or endobronchial intubation. Table support such as the Wilson frame may not allow complete free movement of the abdomen and chest wall. This may reduce dynamic lung compliance and increases in peak airway pressures, especially in the obese. The only recourse may be to return the patient to the supine position if problems develop. Pillows, silicone pads, and other support devices should be used judiciously to protect all pressure areas. Pay particular attention to bony prominences. Ensure that the breast and genitalia are not trapped. Maintenance. Balanced technique, but alterations may be required for SEP or MEP monitoring. Most patients will be paralyzed and ventilated for procedures in a prone position. Care for pressure areas throughout the course of anesthesia. It may be necessary to move the patient's limbs and head every hour to avoid stagnation of peripheral blood and the development of pressure necrosis during long cases. Brachial plexus protection. The arms are usually placed above the head. Brachial plexus are at risk of stretching or being pressed against the mattress. Ensure arm abduction is less than 90 degrees. Ensure axillae are not under tension after positioning. Anticipate and prepare for significant surgical blood loss via good vascular access, accurate blood loss measurement, GXM or GSH. Consider cell salvage. Hypotensive anesthesia may reduce blood loss during major spinal surgery. Target safe MAP for normotensive patients is more than 60 mmHg. Direct arterial monitoring is mandatory. Analgesia will be discussed below. Emergence. Prone position is associated with facial or airway swelling due to dependent edema and may require a period of post-op ventilation. Post-op management. PACO or ICU as required. Plans for the recovery period should be made in advance. Examples of cases requiring ICU or HDU care post-op includes long cases, cases with excessive blood loss, major pediatric cases, and concerns for airway complications. Choice of analgesia depends on the magnitude of the surgery. For example, for minor procedures, NSAIDs with infiltration of the operation site with LA may suffice. Other options include paracetamol, opioids such as PCA morphine, and regional analgesia, such as epidural and paravertebral analgesia. Post-op respiratory function will be compromised if analgesia is inadequate. Incentive spirometry and chest physiotherapy should be commenced post-operatively. Selected emergencies during the prone position. Accidental extubation. Anticipation and planning enables timely management of accidental extubation in the prone position. Check the security and patency of the airway immediately after turning the patient. The bed must not leave the theatre until correct tracheal tube position has been confirmed. If tracheal tube has dislodged, the patient can be turned supine onto the bed and be re-intubated immediately. After any repositioning of the patient or their head, the tracheal tube position should be rechecked. Accidental extubation is unlikely once the patient is positioned and the head and ETT is supported. If the head is supported by pins and the Mayfield clamp, accidental extubation may still occur during surgery if the tracheal tube is free-hanging. Options for airway rescue methods include supraglottic airway devices and fiber optic re-intubation. Placement of the LMA provides a patent airway in the majority of cases, at 87.5% for the first attempt and 100% for the second attempt. Whether to continue surgery with the LMA or to re-secure a tracheal tube should be decided on a case-by-case basis, taking account the nature and duration of the surgery. LMA can be used as a conduit for the passage of a fiber optic scope and tracheal tube in the prone position. Fiber optic re-intubation in the prone position to secure the airway is an option. Anatomy for oral intubation is favorable in the prone position. The tongue falls forward, and this negates the need for jaw thrust or tongue pull. Consider fiber optic re-intubation only if the fiber optic scope is immediately available and the face is easily accessible. For example, the head is secured in pins and the Mayfield clamp. Cardiac arrest. Cardiac arrest in the prone position is a rare event. Case reports have described successful resuscitation and defibrillation in the prone position. CPR should be started with the patient in the prone position while preparing to turn the patient supine. There is no immediate need to turn the patient to the supine position. Posterior compression generates higher mean arterial pressures than anterior compression. The one or two-handed technique may be used with or without counter pressure on the sternum. During CPR, rapidly check the following. Is the patient being ventilated? Is the tracheal tube obstructed, kinked, displaced out of the trachea, or displaced endobronchially? Has breathing circuit disconnection or obstruction occurred? Is the FiO2 appropriate? Ensure all potential causes of asystole are eliminated, such as hypovolemia, hypoxia, acidosis, hypoglycemia, hypo or hyperkalemia, hypothermia, tension pneumothorax, cardiac tamponade, pulmonary thrombosis, coronary thrombosis, and toxins. Were anesthetic drugs given at the correct dose and rate? Any sudden unidentified loss of blood? Operations associated with arrhythmias include operations on the anterior hypothalamus, brainstem, pituitary, trigeminal nerve, neuroendoscopy, use of irrigation fluid of the wrong temperature, surgery triggering vagal reflexes. Preemptive use of anticholinergic drug should be considered in patients at high risk of severe bradycardia or asystole. Transesophageal atrial pacing for severe bradycardia can be performed effectively and safely in the prone position. Methods for chest compressions in the prone position includes by placing a hand over each scapula, compressions over the thoracic spine with or without counter pressure on the sternum, or open cardiac compressions if surgery already involves a thoracotomy. Rarely, the prone position may benefit the patient needing resuscitation when mediastinal masses compresses the trachea or obstruct cardiac filling in the supine position. Some patients will be positioned prone with the aid of a frame, such as the Wilson frame or Welton Hall frame, or pillows to allow free movement of the chest and abdomen. Effective chest compressions may not be effective in these circumstances unless counter pressure from a solid surface is applied. It may be possible to reposition the one under the chest to provide a suitable solid surface if the patient is on blocks. ETCO2 and intra-arterial BP monitoring can be used to confirm clinical diagnosis of cardiac arrest, assess the quality of CPR, and to indicate the return of spontaneous circulation. Ineffective chest compressions in the prone position, as judged by arterial blood pressure monitoring, ETCO2, and lack of a central pulse, may necessitate the patient to be turned back to supine position. However, the presence of an open wound or an unstable spine causes turning the patient supine to be difficult, time-consuming, and dangerous. Once supine, surgical access becomes difficult, and this may result in problems with hemorrhage control. If the anesthetist considers the patient to be at risk of intraoperative cardiac arrest or has a need for pacing or synchronized DC cardioversion, defibrillation pads should be placed prior to turning prone and be checked before commencing surgery. Defibrillator pad positions for successful defibrillation in the prone position includes anterior-posterior, right axilla and cardiac apex, posterolateral, and biaxillary. Additional points for cardiac arrest during neurosurgery in the prone position. Kindly refer to the cardiac arrest in neurosurgery algorithm in conjunction with ALS guidelines published by the Working Group of Resuscitation Council, UK. Wound management. Remove any surgical instruments, pack the wound to reduce blood loss. If the patient's head is fixed in pins, chest compressions or defibrillation may cause movement of the torso against a fixed head, and this risks causing injury to the skull or cervical spine. To reduce the risk of injury, the head should be removed from the pins before defibrillation or chest compressions. Defibrillation may cause burns at the site of insertion of the pins. However, 2 case reports of patients who were defibrillated while remaining in the pins, no mention is made of any apparent injury due to burns at the site of entry of the pins into the scalp and the skull. Another option is to release the clamp from the operation table rather than trying to release the head from the pins. This is faster and safer, reduces the risk of injuring the scalp, resulting in a bleeding pinhole, reduces the risk of operator being injured by the pins, and provides a secure means of holding the patient's head during any move. Secure rest for the patient's head if defibrillation is required. The support of the head, horseshoe type, must be attached to the operation table or the patient moved bodily along the table. Commence CPR while the surgeon supports the patient's head. Ensure that the surgeon is not in contact with the patient when the shock is delivered. CVL-related complication. This is a case report by Saka S.G. et al. In 2001. The CVL was cited with the patient supine, but is complicated by carotid puncture. Airway compromise occurred due to a large hematoma, which developed unobserved after the patient was turned prone. The author's conclusion: the time period for direct pressure over the area should be extended, and repositioning of the patient should be postponed. Prone ventilation for ARDS. This refers to the delivery of mechanical ventilation with the patient lying in the prone position. Indications: for treatment of ARDS as a strategy to improve oxygenation when more traditional modes of ventilation have failed, such as lung protective ventilation, it may be used as a bridge to extracorporeal membrane oxygenation. Degree of hypoxemia and severity of ARDS that warrants prone ventilation: PaO2 to FiO2 ratio of less than 150 mmHg with a FiO2 of 0.6 or more and a PEEP of 5 or more cmH2O. Another criteria is PF ratio of 100 mmHg or less with a PaO2 of less than 60 mmHg despite optimization of the ventilator settings on a FiO2 of 1. Prone positioning does not appear to consistently benefit those with mild or moderate ARDS. Advantages: the prone position improves arterial oxygenation in most patients with ARDS. This is due to improved configuration between the lung and the thorax. There is lung recruitment and more homogeneous lung aeration. Re-expansion of collapsed lung parenchyma in the dorsal lung regions occur. There is reduction in aeration in the ventral lung regions. The heart being dependent results in reduced medial posterior lung compression. This increases homogeneous pleural pressure gradient in the ventral dorsal and cephalocaudal planes, resulting in improved ventilation distribution. There is increased VQ matching, resulting in reduced shunt, increased FRC, and increased end expiratory volume. The abdomen is unsupported when the upper chest and pelvis are supported and the abdomen is suspended. This results in reduced lung compression. The diaphragm becomes displaced caudally. There is reduced compression of the posterior caudal lung parenchyma, and this results in increased diaphragmatic excursion and increased ventilation and oxygenation. When the abdomen is unsupported, there is secretion mobilization. This results in improved bronchial drainage and improved ventilation. There is improved aerosol delivery when the abdomen is unsupported, resulting in improved effect of aerosolized medications and improved ventilation. More homogeneous perfusion. There is increased blood flow to the anterior lung areas, which are the better aerated lung regions during prone positioning. Lung perfusion has been shown to be less dependent on gravity, unlike distribution of ventilation. Previously dependent lung continues to receive the majority of blood flow, independent of gravitational gradient, as the alveoli reopen. Newly dependent lung continues to receive the minority of blood flow as alveoli begin to collapse. Increased lung recruitment and reduced hypoxic pulmonary vasoconstriction results in increased right ventricular preload, reduced right ventricular afterload, reduced pulmonary vascular resistance, and increased cardiac output. There is increased VQ matching due to less dependent perfusion and reduced shunt. Prone positioning reduces ventilator-induced lung injury. Prone positioning causes reduction in difference between the dorsal and ventral transpulmonary pressure. Ventilation becomes more homogeneous. There is reduction in ventral alveolar overinflation and dorsal alveolar collapse, reduction in alveolar distension, reduced villi from overdistension and cyclic atelectasis. Prone positioning improves survival in ARDS by about 10% if prone positioning is started within 48 hours in patients with severe ARDS, based on results from numerous meta-analyses. Prone ventilation is typically more than 16 hours per day. Benefits in COVID-19 patients with respiratory failure. Majority of patients have improved oxygenation during prone positioning, likely due to a better ventilation perfusion matching. A study by Langer et al. In 2021 showed that of 1,057 included patients, mild, moderate, and severe ARDS was present in 15, 50, and 35% of patients, respectively, and had a resulting mortality of 25, 33, and 41%. Prone position was applied in 61% of the patients. Patients placed prone had a more severe disease and died significantly more, 45% versus 33%. Prone position induced a significant increase in PaO2 to FiO2 ratio, while no change in respiratory system compliance or ventilatory ratio was found. Mortality. Patients were classified as oxygen responders, where the PF ratio increased by 20 mmHg or more during prone position, and carbon dioxide responders if the ventilatory ratio was reduced during prone position. ICU mortality was higher in the oxygen non-responders versus the oxygen responders, 65 versus 38%. No differences in terms of ICU mortality was observed for CO2 responders versus non-responders. Timing of initiation of prone ventilation for ARDS. For severe ARDS, after a 12 to 24 hour stabilization period of supine ventilation is recommended. Various trials such as ProSiva demonstrated that early initiation of prone ventilation was most effective. Collapsed lung units are likely to be opened or recruited most easily during the acute exudative phase of ARDS. Positioning. No standard method for moving a patient from supine to prone position exists. This video link shows an example of positioning of the patient prone. Facilities that offer prone ventilation should be educated in its use and have a policy describing all aspects of the procedure. Commercially available beds can initiate, maintain and facilitate prone positioning, reduce risk during turning, and may provide continuous rotation if desired. Ventilation strategies is similar to that employed when the patient is supine. Typically is a lung protective ventilation strategy that incorporates low tidal volumes. Optimal PEEP setting is unknown. Peak and plateau airway pressures may increase immediately after the patient is placed in the prone position and typically declines with time. This is due to reduced chest wall compliance and the mobilization of secretions. Prone ventilation does not require additional monitoring. Employ monitoring as indicated. Airway secretions may increase dramatically, and the need for endotracheal suctioning should be assessed regularly. ECG leads should be placed on the back of the patient. Feeding. Enteral feeding during prone ventilation and usual mouth and skin care can be resumed. However, enteral feeding can be complicated by vomiting and/or increased residual gastric volumes. Consider employing a cautious approach to enteral feeding in a prone position. There must be proper positioning. The head of the patient should be slightly elevated. There should be adequate monitoring for emesis, judicious use of prokinetic agents. Before repositioning back to the supine position, tube feeds should be temporarily switched off and the stomach emptied. Sedation. All patients in whom prone ventilation is performed requires increased sedation. Some require neuromuscular blockade. Procedures. Most procedures are performed in the supine position prior to proning, such as CVL insertion, bronchoscopy, and transport to imaging suites or other units. Duration of prone ventilation. The optimal duration of prone positioning during ARDS is unknown and varies according to the study or center. Some centers have repeated sessions of prone ventilation lasting 6 to 8 hours per day. Some have prolonged prone ventilation lasting 17 to 20 hours per day. Both durations produced similar outcomes. Reduction in frequency of turning severely ill patients decreases the likelihood of complications. Cessation of proning may be considered after signs of improved oxygenation occurs, for example, PF ratio more than 150 mmHg with a FiO2 of 0.6 or less, PEEP of 10 cmH2O or less, maintained for at least 4 hours after the end of the last prone session. The patient may be required to turn back to supine as needed for interim nursing care, for interventions, for acute emergencies, or for surgical procedures. Successful response to prone ventilation. Any positive response is usually observed within the first hour, but delayed responses beyond the first hour have been observed. There will be a sustained improvement in gas exchange. For example, PaO2 increased by more than 10 mmHg on stable ventilator settings. Trials have consistently shown that in most patients with ARDS, up to 70% experience increase in PaO2 during prone ventilation. Some continue to have improved oxygenation for hours after they return to the supine position. Many improve each time prone ventilation is repeated. There is evidence of alveolar recruitment in a successful response. For example, there is increased lung compliance and reduced plateau pressure for a given tidal volume. Failed response to prone ventilation is indicated by no changes in the patient's gas exchange or lung mechanics, worsening of gas exchange or cardiovascular status. In these cases, the patient should be returned to the supine position and alternate strategies for improving oxygenation should be pursued, such as ECMO. Complications reported in literature during prone ventilation for ARDS. Increased need for sedation or paralysis, hypotension or arrhythmias, transient desaturation, airway obstruction, vomiting, loss of venous access, displacement of endotracheal tube, apical atelectasis, obstructed chest tube, dislodged central venous catheter, dislodged hemodialysis catheter, compressed tubing infusing vasoactive medications, pressure point related adverse effects, ischemic optic neuropathy, etc. These are my references. Thank you.